I'm running out of things to say, Drew. Huh?
We can have this person present. It's someone's home computer we're seeing right now.
That's really weird.
Is there anything we can do? Can Travis clean this up?
Want to do right now.
All right.
We have their
Good thing they don't have anything back.
number on it and everything.
It's back up, I guess.
Well, I think, where's Raffi? I think we're going to have to let you get started.
Because we can't.
Huh?
We can't, because we can't see his presentation other than through that person's computer.
Well, we have
Well, we have handouts in the room.
The slides over here.
It's, Raffi, for your knowledge, it's a battle every week to get these broadcasts to work. It is amazing. Unpredictable things go wrong that are just beyond belief. So we can't let them start?
You can start. We just have to go through the handouts until Travis can log that other person out and put our presentation.
This is
Okay,
a new
well, I
problem,
mean,
though, and this is one we haven't seen before. This is we hijacked the computer.
Huh?
This is a new one. Nobody's ever hijacked the computer.
Yeah, that's true. This is probably the RNC who has it.
Yeah.
Yeah, exactly.
Whoever hijacked the computer, please advance.
No, advance.
Well, Raffi, is this the second or third time you've been up here to speak?
At least the second.
Please to say,
Yeah.
he's a multi-talented speaker. He's been up here to talk about HAE before. Nick, what do you want me to do? Get him
Let him
going?
start.
Get me off the stage?
Yeah.
Okay. So, Raffi, I don't want to butcher your last name. I'm terrible with pronunciation. Is from UCLA. You can talk about severe asthma, and hopefully we're going to get a broadcast at some point.
I'll make my presentation in Russian for the hackers. All right, so severe asthma. Len asked me to put together this talk, and I decided to kind of go historic on you and then bring it up to more recent times.
I got an email here from Dennis saying, now we're good. He's one of the outside people who's monitoring this, so maybe the broadcast is good. So go ahead.
I don't think this thing's
It's not
advancing yet.
moving. Oh, you got your mouse working? No.
Someone else is controlling it.
Yeah. Big brother. Big brother.
Can we go to the next slide, please?
Just skip that. He's spiked them. Yes, probably Springer this too.
This proves that we did not land on the moon. There's no way that technology could outperform today's.
Actually, my son-in-law just got back from Iceland, and a lot of the practice for the astronauts was done on Iceland for them going to the moon.
Huh,
Because they have all these weird craters and plains out there, and that's what they did.
that makes
So-
sense.
All right, we're good.
Yeah?
Now we're good?
Cool. All right, so learning objectives, I figured, let's really dig into the evolving definitions of asthma, looking at the pathophysiology and the biomarkers that we're kind of trying to find the holy grail there, and then to talk about clinical guidelines and proper workup. And so we're not going to get into the fellows level of clinic asthma, but kind of look at it from a Google 40,000-foot view. And then approaching the severe asthma endotypes through what we want to do, which is personalized medicine. And at this point, I think we've gone from global asthma approach to maybe regional is as good as we are. When we look at the epidemiology of asthma, obviously a lot of cost and burden that I will not go into details due to time at this point. And then the prevalence of childhood, certainly, and leading into adult asthma, when we look at a couple of decades before and trying to predict these extrapolations and seeing that, wow, every couple of decades we're doubling in the prevalence of asthma. Well, genetics can't prove that. You can't be mutating within a lifetime to show this increase. So therefore, you got to believe in the genetic and environmental play. And then some people decided, well, maybe I can predict who's going to have asthma based on whether you have so many wheezing episodes in the previous year, with one major criterion. Maybe your parent has asthma, therefore you've got a good chance of having asthma versus a couple of minor criteria where you can see eosinophils here, for instance, playing a role. And leading on to Fernando Martinez's analysis of let's grab about 800 kids and track their moms themselves through childhood and see if there's a predictable model there where you've got the transient early wheezers that are the kids that you want to have been associated with maternal smoking, for instance, to the non-atopic wheezers who will sort of start wheezing around age 3 and start coming out of that around 6 to 11 years of age. So those are the ones with the RSV bronchiolitis exposure. And the IgE-mediated or associated wheezers, who, those are your typical, when we say, oh, 70, 80% of asthma is allergic. So those are the ones that are sensitized and will continue to wheeze, especially when they're exposed to that sensitized trigger. And then came the 700 plus tome, 700 plus page NIH guideline in 2007, which should be updated very soon with expanded steps in categorizing severity and control. And here, the key definitions, obviously, which have been board questions all along, so fellows, a toss-up here. At that first visit, when you get a naive or a existing asthma patient, you want to reassess that severity or assess it for the first time, and at least put them on the playing field. Are they asthmatic? Yes, no, based on cough, wheeze, shortness of breath, or chest tightness. And give it a name. And you might be completely off. And I always say, I've once in a while messed up a patient who says, I use my albuterol daily, and that's it. If you had just 2 seconds of an interaction, you're saying albuterol daily. That must be at least a moderate persistent asthma, right, in severity. But then they might come back on the next visit and you kind of blasted them with steroids or llamas and so on. And they say, I don't know why you added all that stuff. I use it for my exercise every day. All right, well, I don't think you killed them. Now you can readjust and just say, are you under control? So at each subsequent visit, you want to assess control, control, control. And for the attendings and fellows on your notes, that's essentially what all these MIPS and wizard and all the meaningful use criteria that we're trying to document on a note are looking for, not just in this disease, but other disease states as well. You have this severity, you want to show that because now the meds are getting costlier. Are you under control now based on that medication? Otherwise, it's get off the potty and change course. And obviously how well the patient's responding to that controlling therapy. And there are a couple of domains, impairment and risk, in that guideline, which are looking at the everything from bronchodilator use to quality of life, lung function, and the risks, obviously, essentially having those exacerbations that require oral corticosteroids and or hospitalization and beyond. So you want to reduce impairment, you want to reduce risk, and once you assess that severity, now you've got at least some guidelines, and I'll step into Gina in a second, to kind of give you beyond your landing point, somewhere to start in the therapy and treat this patient. And obviously with each subsequent visit, when you're looking at control, you want to look at not just monitoring the therapy and adjusting it, but also the side effects of the therapy to make sure that the deleterious effects are minimized, if not obviated. I just wanted to use the term obviated for that. So 3 key figures in that guideline have been the severity, the stepwise approach, and the control. Now, some of the reasons why this asthmatic is not controlled or well controlled. Well, they might have poor adherence. And I know that there are a lot of techniques on the horizon or gadgets and, is this inhaler working, Bluetoothing it, etc. But we know that from studies, a lot of patients will come in and just take all their pumps in the parking lot and go, here you go, doc, for the clinical trial. I did it all in the last month, right? Just recently I had a clinical trial patient for a different disease state who had a bunch of pills that she brought back. She's like, well, I want to keep them because they work. Well, if they worked, why aren't you taking them, right? Well, I kind of wanted to stockpile for later. We got to turn him in. Have we underestimated the severity of that asthmatic or overestimated it for that reason? So, but that's why frequent follow-ups will help. Have we taken into consideration the environmental factors, right? And I almost say it's an almanac. In Los Angeles, I mean, we're bookended by the Torrance and Carson refineries with a nice big American flag in front of it to hide the smokestacks, which is a double insult. And then this Porter Ranch gas leak that caused all kinds of mayhem. And so I'm always looking at what's the air quality like. And back in the 80s, for those of you who grew up in LA or been through LA, we used to have smog alert days. But those were all for the big 3 micron plus particles. Now the companies are smarter. They're like, hey, chemists, blow my crap up at less than 3 microns. We'll fly right under the EPA guidelines for that smog alert. And so you're no longer getting that burn in your throat to give you the warning of you're going to wheeze. Instead, we're getting into nanoparticle ranges where they could pretty much go through you and you won't even know what hit you. And it's an immune reaction that might hit you in 24 or 48 hours later. And you're thinking, what did I do in the last 6 hours to get to this state? And you start losing your compass. And then there are other comorbidities such as obesity, reflux. I mean, it's silly because having done pediatrics, there's at least one study a year from the AAP going, 6 hamburgers a week gives you worse asthma than 1 hamburger a week for a kid. It's like, no duh, Sherlock. But, stating the obvious, but it reminds us that there's more. I mean, I could personally tell you if I eat a lot of wheat products or gluten, as I order a side of gluten on purpose sometimes at a restaurant, I will have wheezing and chest tightness. This is all to tell you that it matters on what kind of octane you're putting in your body as well. So, fast forward to 2019's GINA report, which integrated essentially evidence-based strategies to look at the translational piece. So we've got all this science and we've got all this clinical stuff, but we need to kind of meld it in the middle. And so for a new therapy, you essentially need 2 good quality studies plus information from the governing bodies to put this into the guidelines, which is a step up in quality. And it removed the use of SABA only from treatment in step 1. So it's a lot more aggressive in starting the game for an asthmatic. And the emphasis on low-dose ICS as an introduction to reduce risk of serious exacerbation exists now in that step 1. But again, it's introducing that low-dose ICS. Keep that in mind because I talked to the fellows last night, and it's no longer a one-size-fits-all as we did with Donata Vercelli. I held a session where Jeff Drazen showed up actually a couple of years ago at the Quad AI to look at personalized medicine. Where are we going with asthma, right? You can no longer be blasting people with this general consensus of, oh, there's a 70% or 80% effect in reducing exacerbations by using ICS. Because we got minorities, and no pun intended, that may have a reverse reaction, actual quicker death, which I'll show you in a second, that get melted into that statistic where if you did it right and chose your target population, you might have a 100% response. And we should no longer be happy with, oh, we got a 70, 80% like improvement in our state of asthma control.
Does that last statement mean we should be using low-dose ICS in intermittent asthma?
No, so this last statement is essentially saying these guidelines, GINA guidelines, use that aggressively, ICS. But what I'm saying is the next GINA iteration should really say it should be even more personalized. Instead of a shotgun approach of a low ICS, a little more of a laser approach. So, need obviously drives innovation, and asthma is still one of the leading causes of death, and it can hit you pretty fast, right? COPD is accelerated death, right? You're slowly dying, less oxygen, you need more support, and so on. Asthma can kill you in 1 day. We know this. Actually, that's what drove me into allergy partly. I was at Cambridge Hospital as a resident one day, and a guy my age, my demographics, got gurneyed in with his cleats next to him, And I sat there like an idiot, just doing CPR for an extra 40 minutes, and they're all laughing at me, thinking, we're going to revive this guy. He was basically asthma on the field playing soccer and just went down. Not cardiac, pulmonary demise. And so there's variability between and within patients, and the variability of outcomes is also something that we need to keep an eye on. And when we step back and take that traditional definition of asthma, it's essentially what you guys learned from med school even. So the trifecta of airway narrowing that may be reversible, inflammation, and this hyperresponsiveness to various stimuli. But the popular definition is also quite informative in that it's episodic dyspnea or cough, generally associated with wheezing, and usually improves with inhaled beta agonists. And so we tried to find the balance a few years ago, right? Hygiene hypothesis, like what's driving Th1 versus Th2 skewing? And we see that with Th2 skewing, you've got sensitization to perennial allergens, for instance. You've got the healthier environment, vaccination, hygiene, and so on, that drives some of this allergic asthma phenotype. And we've looked at genes forever, right? Everything from ADAM33 when I was going through residency, that was a big one, to more recently IgE, IL-4, IL-5, IL-13, and so on. And so when we look at therapies too, it's important to see where in this tree with its roots and branches are we trying to stop things. And so how can we assess that severity? This is a picture from the, I think it was the 2010 World Cup with the vuvuzelas in South Africa. And so pediatric asthma deaths, when we look at prediction of fatality, it's actually even across the board due to both physician or clinician misinterpretation or severity assessment, as well as patient self-assessment. So there's an equal chance of dying whether you're severe, moderate, or mild asthmatic, which just tells you biases, I might have a gender bias versus an age bias versus a regional bias, athlete, non-athlete. And then what's really shocking is, and these numbers continue, there's up to a 10-fold disparity in African American versus Caucasian white death rates from pediatric asthma. And in this day and age, I might give you a 1.5 to 2 times differential to say, all right, maybe there's a little less access to care, the air quality might be a little worse in certain neighborhoods versus others. But to have that kind of a disparity, to me, having done epidemiology before medicine, points to there's something quite genetic and environmentally wrong going on here that we're not paying attention to. And so when we try to redefine asthma, is it a single disease still, which I call a trash can term, you used it last night, with variable presentations, or is it several diseases with a variable obstructive flow that's in common? And we should throw in COPD in there, ACO, and so on. And there are large cohorts of asthma patients that don't show this to be that kind of a reliable umbrella measure. And there's a lack of reproducible association between asthma and its genetic variants. Funny enough, years ago, an English physician looked at 90 asthma patients treated with oral prednisolone. A little over half of them had marked improvement. 10 of them had a partial response, and 23 had no benefit. All right? He found that sputum eosinophils were in 63, the majority of the patients who responded. So you talk about this guy in the 50s doing personalized medicine in a way. The non-responders had no eosinophils. So it makes sense, right? From today's perspective, the steroids did not work in the non-eosinophilic asthmatics. And even in the responders, he called out that corticosteroids only suppressed the asthmatic state, meaning as soon as the prednisolone was off, they reverted back to their asthmatic symptomatology. And so from that point till now, I mean, it took a few decades, and we talk about the technology here and landing a person on the moon right around the time I was born. Yeah, I hit 50. Thanks a lot. And some of you are awake at my joke. So now we look at the T2 skewing, right? The cytokines looking at IL-4, IL-5, IL-13. And these are the typical cytokines in what we kind of throw as a batch, the 70 or 80% of asthmatics that are allergic. And we look at a deeper dive with the Th2 cells, with the type 2 innate lymphoid cells, mast cells, IL-5, IL-13, and the gene expression from this batch that is attributable to the worsening of asthma control. And when we look at biomarkers, we're trying to get predictive medicine essentially to see if the therapy is going to work. So that, again, as therapies are getting more expensive, you're not trying to just go, you know, in the old days, just try this nasal spray. It's only 70 bucks, which back then was like 70 bucks. Well, that doesn't work. Try the 61 and you try the $100 one. We'll just keep shuffling around. We can't do that because we know that some of these biologics we're using every 2 weeks to a month, every couple of months, and you don't have that much time. Like I said, an asthmatic could die in 1 day, so you want to land on a pretty good spot. And so we're looking at the characterization of the cytokine patterns, the cell populations in the airway and the blood, the proteins in the serum, and the exhaled gases. So it's almost like taking your car for that, 100,000-mile workup where you got something in the muffler, something in the engine, all these probes and so on. And the main kind of star until now has been the eosinophils because we can measure them in the blood easily. And from there we've had 3 agents, right? A couple of IL-5 blockers and an IL-5 receptor blocker. And so when we look at the eosinophilia, it's a good marker for T2 inflammation. In fact, some of the labels have an eosinophilic phenotype to say a T2 skewing. And we know that thresholds, we've used 150 or 300 peripheral cells to mark that this is a patient with a T2 skewing. And you'll see that that really hits about half of the asthmatics in that pile. And sputum eosinophilia is present in allergic asthma and late onset eosinophilic asthma as endotypes, so to speak. And you'll see that the adult onset asthmatics with EOs greater than 300 tend to be more male with higher phenos, more sputum eosinophilia, worsening lung function, and a history of allergic or atopic comorbidities. When we look at another biomarker, pheno, which go ahead and poo-poo that right now, because both on the private clinic side and in the institutional side, it's cost prohibitive sometimes, right? With the mouthpiece and all that stuff. But it's
actually in our community here, it's most everybody's paying for it, and it has become cost effective. At least that's my impression. Doing it much more widely.
okay.
For a long time, we weren't getting reimbursed, and it wasn't being done. But
Yeah.
we're using it a lot.
Good.
I am. Yes.
So, in other words, what this should all kind of melt into is a good scoring system. Like you mentioned Canada, the Montreal asthma score, right? With taking into consideration your eosinophil count, your IgEs, your pheno. We're not doing that yet, and I mean we don't have a big enough study to do this yet. But I think the more you get, and we know this from PFT plus ENO in non-commercial, non-therapeutic asthma in assessing severity, you get a better measure because you're never going to catch the entire population based on one measure. And the pheno is really helpful because it's a biomarker of T2 inflammation. It's increased in patients with airway eosinophilia. It's not a great indicator for eosinophil presence in the airway and doesn't accurately predict sputum eosinophilia, but it is recommended by GINA in that it's non-invasive, easy to use, and the cutoff, under 25 parts per billion means that you're not emitting this proxy of airway inflammation in the T2 skewed pattern. I don't know what I did here. So NO is basically produced by nitric oxide synthase in the respiratory epithelium under the direct control of IL-13. And that's an important piece to know. So yes, it's a marker or proxy for eosinophilic or T2 skewing, but it's really under the control of IL-13 in the airway epithelium, and it's reproducible, and you'd expect that nitric oxide reduction will occur with IL-13 inhibition, but not necessarily with eosinophil or IL-5 inhibition. Why do I say that? Because sometimes, and I mentioned this last night, I'll get a second or third opinion for a patient who's been rejected by an IL-5 or an IL-5 receptor blockade therapy because the clinician said we should now expect nitric oxide to come down, and it may not. And in the end, we should expect exacerbations and presenteeism and quality of life to go down and go up, right? That kind of an improvement. And so then the payer might say, well, you said the nitric oxide should come down, and it stayed the same or even went up a little bit. And no one's listening to the patient who's saying, now I'm able to go bike and, bike to work, etc. But we can't also forget the B and T cell dance, right? As they interact and cause class switching in IgE synthesis. And so along with the skin testing that we do, this is a good marker for atopy. And this is found, like I said, in 80% of the early onset asthmatics and 50% of the late onset eosinophilic asthma patients. Follicular TH cells are essentially responsible in what you guys are learning in first year, isotype switching and affinity maturation. And yes, it's still helpful to use the total serum IgE, even in the absence of skin testing or specific IgEs. And the proof of concept here was that in mild persistent asthmatics, reduction in IgE through omalizumab led to reduction in lymphocytic and eosinophilic inflammation in the airway. And IgE therefore has a pivotal role in asthma exacerbations, and that pathway helps prevent the mast cell activation through allergen binding and binding in dendritic cells and causing reduction in interferon release and impaired viral killing. And as far as combining that IgE with nitric oxide, you can see from Nick Hanania's study that a high level of FeNO showed, and use of omalizumab showed higher efficacy in reducing exacerbations versus patients who had a lower nitric oxide profile. So now you're getting the interaction with biomarkers. And let's not forget neutrophilic asthma, right? When you look at fatal asthma, what's in the airway at that point? You're past eosinophilia, you have neutrophils. But you got the neutrophilic phenotype as well, where this is associated with the Th1 high endotype, and in combination sometimes with eosinophils, but could occur in an isolated fashion. It correlates with higher levels of severity. And there are other non-T2 markers that we should also consider. IL-6, which most recently we identified an IL-4 receptor alpha chain mutation in African Americans that leads to, that's got higher fatality that goes through the IL-6 pathway, that if there's time I'll show you some data on that. And various other modulators, including IL-17. So when we look at biomarkers, unfortunately for the IL-4 receptor, we don't have a commercially available marker and have to use some of these proxies. But we know that airway IL-13 is found to correlate with epithelial proteins such as periostin and diphosphatase peptidyl 4, DPP4. Both are secreted by the epithelium into the blood and serve as serum biomarkers for assessing IL-13 inflammation. To date, these have not been shown to be clinically superior to blood eosinophils or exhaled nitric oxide, but that work's still developing. And so when we look at IL-4, IL-13 in combination, we know that these receptors are expressed in various innate as well as more developed systems and the structure of the airway. And so to summarize, I grabbed this basically from one of the more recent Jackie publications, and it has essentially in sequence of what's developed as far as our treatment with the IgE antagonization, IL-5 and receptor antagonization, IL-4 and 13, and more recently predictively TSLP, which it's speculative here. And so other targets, I mean, the list could go on forever here. As you know, we've got anti-IL-13 in the development, all the way down to IL-33 and more. And I just heard from some of you guys that the Viprapant did not make the cut, apparently, the oral antagonist. So essentially, when we step back, it's time to really redefine asthma that is probably divided into several disease entities, and I think you'll agree, with specific mechanisms that we call endotypes. So we've gone from phenotypes in a way to genotypes as the machinery in the labs got more expensive and our toys got nicer, to now endotypes, to start profiling people, much like I get profiled at the TSA, for instance. I do. I was at LAX yesterday. All the ladies got to go through the magnet, the scanner. Sorry, the metal detector, and I'm going through the scanner. I told the guy, "How do you decide?" He goes, "I decide." It's like color, isn't it? So, definition of an endotype. It's a subtype of a condition defined by a distinct pathophysiological mechanism. So that kind of helps you define what's the workings and what should or should not work to a fairly good extent. And it's a distinct functional pathophysiological mechanism. It's different from phenotyping, as it describes a distinct disease entity with an etiology and pathophysiological response. And it helps really predict treatment response and facilitates the management decisions that we all struggle with the available therapies. Because much like, so I have a little nonprofit for kids with chronic illness and bringing them music therapy. And the question we always say is we're struggling with raising money. What would happen if we had $1 million right now? And you start freaking out. It's almost like you think you're struggling with asthma or your patients are struggling with asthma. Pretend that list of everything up until IL-17, blockade, 33. Pretend I just gave it all to you, or Bill Gates just gave you a huge donation. What would you do now? We'd still have to go back to the drawing board and think, like, do I know all my pathophysiological mechanisms well? And we're not there yet. So another asthma endotype would be the Th17 pathway, which is involved in humoral responses to the extracellular pathogens and recruits neutrophils. So now it gets interesting, huh? You mentioned neutrophils at the end. And it's a key cytokine with direct involvement in asthma development. It is marked by corticosteroid resistance. Remember when I said early on, ICS, low dose ICS for everyone? Well, we also know lessons from COPD, right, that corticosteroids may not help COPD necessarily, that it has to do with methylation, demethylation. And so compared to the T2 skewed patients, these patients have lower eosinophil counts and nitric oxide, right? So now you're seeing, wow, yet another person coming through your TSA scanner. And then you've got high CCAM6 expression in the bronchial epithelium and neutrophils greater than those in T2 asthma patients.
What's CCAM6?
CCAM6, it's also in the epithelium. You're stumping me on that one. It's one of the adhesion molecules and basically lymphocyte chemoattractants. But I'll get back to you with the exact definition.
I'll forget it anyway.
As I did. And so when we look at all the asthma endotypes, now we've got Venn diagrams going on with, is it Th1 high, is it Th2 high, is it a combo, low T cell, but you can see how you can start kind of isolating the patient into more of a, this type of class should work versus may not. And so I'll introduce here, how are we doing on time?
Good. 20
Good,
minutes.
okay. So I'll introduce here the IL-4 receptor alpha polymorphism that I started working on, one of the two, in fellowship. And so the Q576R, which is a glutamine to arginine substitution in the IL-4 receptor alpha chain, tail, is present in 50% of African Americans in a homozygous pattern. It screams for severe asthma, it screams for rapid lung function decline in smokers, and it is associated with RSV bronchiolitis exposed inflammation and wheezing. Now, when we worked this out, Talal Shatila, who was my chairman at the time, and I used to butt heads because he thought every IL-4 receptor phenotype behaves through STAT6 modulation, right? And that's a board question, actually. IL-4, STAT6, right? That's your signal transduction and transcription factor for IL-4 inflammation. But this one, I basically told him I'm going to save you a lot of money by not running any more gels because this crap is not working anymore. Did not behave through STAT6, but rather through ERK and MAP kinase, which traditionally have been known as the steroid-resistant pathways. And so when you look at the mice, which, by the way, this is a great experiment because the background is exactly identical in mice and human beings. You've got screaming goblet cells along the pathway of the airway epithelium, lymphocytes, eosinophils, and you've got easy sensitization to ovalbumin. IgE starts going up, and it's a severe asthma-associated polymorphism in that it converts inducible regulatory T cells towards Th17 inflammation. And that skewing is mediated through some intermediaries like GRUB2, which are beyond the talk today, but essentially involve IL-6 and STAT3. So now you can see that within this canonical pathway that we thought everything is known, there's more devil in the details. These little polymorphisms start behaving differently and might respond differently. So the analogy here I'll make is some of the big pharma companies tried to take on Alzheimer's, right, with immunoglobulins. Big failure. Well, I think any 25-year-old master's level student could have told you that. Don't be getting a 40-year-old and an 80-year-old with dementia and put them in the same block and say, one size fits all. Because now you're going for the kill instead of saying, let me find my niche and personalize the medicine and find a therapy that's going to work for a subgroup.
Well, that's the same story why mepolizumab originally failed.
Mm-hmm.
They took on all asthmatics.
And we were just talking about that back there. Yeah, that was about 20 years ago. Yeah.
Is this a natural mutation in mice, or you have to create mice that have this?
You have to knock it in. Yeah. Although LA mice, I think, have asthma too. So you've got some specific deletions in the genes that regulate Th17 differentiation, but not IL-4 or IL-13. And the development of a mixed Th2 and Th17 cell inflammation in these genetically prone individuals will show you that interventions that stabilize inducible Tregs would be helpful. And so carrying on that work further, we could see that by using anti-IL-6, for instance, for this one, and I'm not promoting anything here, really helps the IL-4 and IL-13 cytokine pattern and signature in the airway. And you can read more about this with two cases that I'm working on with the Boston Children's Group, pediatric cases that were in the ICU literally every other month and now have been hospital-free for a few months with this experimental approach. So again, getting a little more personalized. So what's next for asthma? As I just showed you, some receptor tails have certain polymorphisms that don't follow the known pathways that are in the textbook, which is why it's good to read the journals. And that precision medicine paradigm is getting deeper and a little more resolved. And we need more studies. I love this saying. So at Mass General, during grand rounds, if you had nothing better to say, you have to come up with something stupid brilliant. And this one time, I was just oblivious. 48 hours on call. Yes, we used to do that. And the chief said, any words of wisdom? And I said, short-term studies have shown that long-term studies are more effective. That was it. All right. Get out of here. But you always end with more studies are needed, and the genotyping does help us support that endotype resolution, believe it or not. So again, pointing to more, it's like your DNA, there's no garbage. You know, as we dig deeper and understand more, nothing's really wasted. It's just we're not reading the in-between stuff. And so what should go into the endotype formula? Well, we've got clusters of measurements from various disease dimensions, right? Different specialties. That's why the conferences help. We've got evolving endotypes. And last I checked, we got the aspirin-sensitive one, the allergic bronchopulmonary mycotic one, the allergic adult, the preschool wheezer, the severe late onset asthmatic, the hypereosinophilic one, and the cross-country female skier, if you know this one.
No.
So if you're a female and you're involved in aerobic activities with cold, that's why it's a cross-country skier, right, not a slalom skier, that's another endotype, that's where it expresses itself.
It's getting a little too personalized.
It is. So get out of my business. And so do we need a hierarchical approach? And where do these polymorphic pathways fall within this kind of paradigm? Because it's great that you're kind of doing a phenoendotype, but then there's like micro minutia within the genotype that we need to keep our eyes on. And so based on these endotypes, we cannot administer corticosteroids to all comers, all right? And we look at some of the variabilities within geno, pheno, and endo, and think about endotyping, because that's what's helping drive the existence of the expression of the phenotype.
I thought that you just told us the newest GINA guidelines introduced corticosteroids earlier. They sort of contradict your second point there.
Bingo. So
who's right?
that's GINA 2019. What I'm hoping is, as we get better, the two studies with some FDA or European governing body approvals, that we don't necessarily just start with corticosteroids. I mean, that might be good to stop the bleed, but we may be able to kind of just target, cauterize the asthmatic bleed earlier, hopefully, as we understand more, so that low dose or high dose ICS is not the first intervention. Because as I showed you, in African Americans, for instance, who carry that genetic background, it might be detrimental to treat them with a low or high dose ICS as the first therapy. And so polymorphisms will be part of this formula, and treatment thus far remains chronic with no disease modifiers, but that's being worked on as well with some of the perinatal monoclonals that I was telling you about last night. And so what's next for asthma? A small proportion of the patients with asthma will be poorly controlled despite regular use of inhaled maintenance therapies, which are still the norm. And the majority of these patients have a type 2 molecular shift in the phenotype and relevant specific IgEs. And these therapies are directed at allergic, such as omalizumab, and type 2 processes, IL-4, 5, and 13, to reduce the exacerbations, which is still the FDA #1 primary endpoint. That with a close second, FEV1 changes. All right, and we were just talking about with some of you before the lecture today, what if the patient says, I'm having the same amount of exacerbations, please don't change it because now I can actually do X, Y, and Z. All right, or my FEV1, great, your machine shows that I'm the same as a year ago, but I'm doing phenomenally better. And so upstream epithelial cytokines, two examples, TSLP, IL-13, may have a broader effect on asthma pathogenesis. We don't know. They might also have some other deleterious effects by being higher up. And so we need to have cluster analyses to show some more insight into this paradigm. An omics approach, whether it be microbiomics, it's funny, I have a childhood friend who's a big shot at Caltech now. The guy wants to define his microbiomics to define everything from MS to asthma to food allergy and so on. And that's very research or job security driven medicine, you know, as I tell them. And so we've got to essentially get to precision medicine, and we're getting it. We are more precise. That's the good news today. And what's still unclear is how these phenotypes and endotypes can guide that care in the office once the patient sees you, and the need for better biomarkers as we develop them to help us really land on the best area of the page and guide that therapy to get the best outcomes. So a quick post-test. I tried to make these as simple as possible. Which of the following are included in the NIH guidelines as impairment domains? Which I didn't go through these necessarily, but you might get this on board exams, essentially. Daytime symptoms, I see yes. People shaking their heads, I'm not looking at you. Nighttime symptoms, Use of bronchodilator. A good landing spot is if you're using your bronchodilator daily, that's moderate persistent asthma. More than once a day is severe. All right. Limitation in activity, so essentially all the above. Which of the following biologics are approved for moderate to severe asthma? I think you got everybody back there shaking their heads. Oh yeah, that's me right there. And then which of the following is the principal cytokine responsible for nitric oxide development in the airway?
13.
Yeah,
You taught us that.
there you go. And I don't know who put this in there, but word of the day is airway apparently.
That's what people get the CME credit.
Oh, gotcha, gotcha.
So you're not supposed to be commercial here, but how do you think about use of the new biologics when you have a moderately severe patient? How are you making those choices?
Yeah, so I think you asked me yesterday, how many patients do you have on biologics? And to the dismay of some of the reps and company folks, they're like, you know, so-and-so down the street has 40 patients on this. And I'm like, okay. So it goes back to if we had a gazillion bucks and had everything on the table available to us, I'd still trepidate with the knowledge we have now on what to start someone on. And so I want to be darn sure that their signature, their profile will mesh well with the treatment that we put them on. So with all that said, I'm still kind of a little conservative with the genotype approaches, right? ICS, low dose, see if they respond. Unless I'm thinking, wow, this person might have some seriously deleterious effects. And the rest is the known demographics. So when you look at the products that are out there, look at what kind of patients entered the study. I mean, that's on the second or third slide if you go to a talk or in the package insert. So see if your patient's kind of falling in that pathway or in that follows that group. And the measures that were used, right? Whether it be nitric oxide if it was available, eosinophil count if it was available, IgE count if it was available, and what you're trying to do with that patient. Because one patient might come to you and go, I feel great, but it just bugs me that my FEV1 sucks. Versus another one going, man, IgE, am I going to die from having a 500 for an IgE, right? Or an eosinophil count of 450. So I'm not trying to kind of sidestep your question with my answer, but it's work in progress.
With mucocutaneous candidiasis, it's an IL-17 defect there. Is that crossover to any of this? That IL-17 keeps coming up more and more now as you're speaking.
Yeah. Again, you're going to have to look at the pros and cons of therapy. So that applies right there. DPP-4 is used, if I'm not mistaken, in insulin-resistant or non-insulin-resistant diabetes. So inhibiting versus promoting some of these pathways, you got to look at the opposite side, for sure. And we're trying to get more targeted, but sometimes just blocking one road might cause mayhem in the rest of the system.
Collateral damage.
Yeah.
Do you think we'll get to a point where there'll be like multiple biomarkers? You've seen the utility of analyses of FeNO and maybe urinary leukotrienes, sputum eosinophils, blood eosinophils, or maybe a biopsy thrown in there, or affect your T cells by fax? I mean, do you think with the personalized approach in the future it'll be something like that, or do you think that's not going to be a fruitful approach?
I think it will be. Again, we're going to have to create scores. It's not going to land exactly on the spot, but it'll be better than certainly just measuring, in this clinic we have a spirometer only. In the other clinic we have a nitric oxide only. The other one we do biopsies, impulse oscillometry, and so on. But I think the more data you have and you can plug into the equation, now you create almost like a logistic regression model to say, if I just had this being a 0 or a 1 for you, everything else, everyone else in the crowd is going to have your age, your gender, your color eyes, but your nitric oxide is a 28 and everyone else's is a 15. Aha, this drug will work best on you. So it's going to have to be that kind of a composite score.
My concern is that the science is great. There's going to be a point when the money runs out. Society can't afford, I don't think, we were talking about this earlier, some of what we're doing here. Not everybody can be individualized with so much testing. You can watch the political debate going on in this country, and I don't think there's going to be enough money in society to do this for all the chronic diseases that we deal with. That's just a philosophical comment, but I think it might be real in the end as well.
Len and I were having that exact conversation, but assuming that you do have unlimited funds and you're going to see these refractory asthmatics, what would be your screen to look at these people to decide what form of therapy to put them on? Do you have a sort of a package of tests that you said these are what we need to do?
So most of my clinic work is in a private practice. I'm limited to the eosinophil count, the IgE count, the nitric oxide, the pulmonary function.
Same as the rest of us.
Yeah.
Just like the rest of
Because outside of that, I'd be driving up costs as well. And yeah, and then what do I do?
So for the African American patients that don't necessarily respond to inhaled corticosteroids, you would talk about you have sometimes a different approach or consider a different approach. What do you reach for first in them? Do you go for like a leukotriene receptor antagonist? Do you go for something different? What do you think?
Right, so I'll emphasize more LAMA. Now, that said, the bulk of the African American kids are actually in the breathmobile catchment area that we go to, because our clinic is heavily Caucasian white. So I don't have that much experience to go off of, but yeah, if I saw that they're not going to do well or there are other comorbidities involved, I'm going to try to chop down those first. So avoidance instead of adding on stuff that might kind of downward spiral them.
This may be only good for me and Nick and Bill, but back in the old days, we found out this polymorphism in blacks. We didn't know what it was, but we knew when we gave them unopposed bronchodilators, they died more than everybody else. If you go back to that group, is this the polymorphism that we didn't know about?
No, that was the arch-gly-gly
Right.
you're talking about? Yeah.
So this is a different polymorphism then?
Yeah.
So what happened to the scientific meaning of that previous?
The previous one?
Yeah, we blamed the SMART trial on that.
Exactly.
Right?
With the long-acting
Yeah.
beta agonist.
Right.
I think society and the company and so on, they just plowed through and said, as long as you use an inhaled corticosteroid with it, you should be able to suppress it, to prevent deaths.
And,
But-
and just an aside, what are you facing right now just with asthma rates in the pediatric population in LA with just that unique combination of the frequent wildfires now and the large urban population with a diesel, background with all the car traffic? So what are you seeing?
The work Andy Saxon did years ago, diesel pollution.
Or just like currently, I mean, you've had two major
Fires, yeah, the gas leaks. So to me, it's also important to use, right? I always say, take away all this stuff, computers, screen. What are you left with? Your ears to put up against the chest or a stethoscope. And so when you look at the inner city kids who are under those fires daily, it's a bidirectional, beyond wheeze. It's just a washing machine in there. And it just doesn't go with classic asthma that you listen to a kid in a suburb who all of a sudden got exposed to aspergillus or rolling around in hay or whatever it might be. It's seriously like accelerated lung death is what you're hearing. So for those, what the university wants you to lecture is make sure you eat your good diet, and the kid's like obese, looking at you saying, I'm having an apple in the morning. They're doing all the right things, but they're in such a catch-22 that they cannot go outside to exercise because their lungs won't allow them. And even if they did, they go outside, get inflamed, which probably worsens some of the adiposity and so on, and they're going to end up right back inside, just kind of bracing themselves, splinting their torso, basically. So how do I diagnose those or treat those? Sadly, it's, well, first of all, they don't have insurance, so it's playing good cop, bad cop, you know, providing them samples and so on to treat them and ration it till the next time you show up there. And essentially telling the parents, if you can move, move.
But has there been like an increase in asthma admissions at like LA County or?
That data I don't
Fatalities?
have. Yeah, and we were talking about, I mean, there's something bizarre about, like, we don't see steroid-dependent asthmatics. Pulmonologists do. So there's a weird selection or entry bias that we're not seeing those. Admissions to hospitals with asthma exacerbations, to my knowledge, have gone down. So how are they being managed? I don't know. It could be one pediatrician who's like nuking everyone with oral corticosteroids that we don't know about. But there's a bias there because I don't know about that tree that's falling in the forest.
All right, well, Raffi, thank you for coming. Next time we'll try and have sunshine.
Therapists down there in LA.
Speedy recovery.
Yeah, it's gotta be.
Oh, it's really, I was in the fellowship, these fires were horrible.
Oh, right, you were in San Francisco and all those.
Oh, it was like bad. And I